All right, so thanks for coming. Today we are very excited to be joined by Allison Hoffman. She's a professor at the University of Pennsylvania Carey School of Law and an author of numerous articles on health insurance regulation and healthcare law and policy more generally. Her body of work is, to me, noteworthy for its ability to make concrete and practical policy proposals that are radical and have the opportunity to make dramatic improvements on all of our lives, while also cutting through profound conceptual questions. Today, she'll be sharing with us part of her project to imagine a better way to pay for healthcare in the United States. And before we begin, I'd like to advertise our next meeting, which will be held 2 weeks from now. On October 20th, we'll be joined by Professors John Goldberg and Ben Sapersky, who will be sharing with us some thoughts on the role that insurance plays in their influential theory of tort law, which they recently laid out in their book, Recognizing Wrongs. So with that, I'll hand it off to Professor Hoffman.
Great. Hi, everyone. It's really nice to be here with you today. So I want to talk a little bit about health insurance and in particular the job-based nature of health insurance. And we rely heavily on jobs to connect people with their health benefits. Doing so has a lot of problems. Some have existed for a long time, some have increased over the last few decades and became really quite obvious over the pandemic. And the pandemic really made a lot of us question the wisdom of this system that we've been thinking about for a while, but kind of renewed those kinds of questions. So in the next 30 minutes or so, I'll talk a little bit about how this reliance began and how the foundation that this job-based coverage that we've been relying on has begun to crumble over time. And then I'll highlight a few different proposals for what to do about that in the years to come. And I'll focus on one that I developed with a couple of co-authors for something called an employer public option. So let me start by just giving you a little bit of background on job-based health insurance. About half of all health insurance in the US comes from a job. And so this is the kind of the basic overview of employer sponsored health insurance, or job-based coverage as I call it, on the right-hand side, which is about 50% of coverage. And then you see the other major slices. The piece here, Medicare, is about 17% of coverage, Medicaid, and the Children's Health Insurance Program. These are the public health insurance programs, and they're about a third of all coverage together. This individual market, this is mostly your ACA marketplace coverage, where people don't have insurance generally through a job and they don't qualify for public coverage. And so they go to one of these marketplaces and they sign up to get a policy on their own for themselves or for their family. And then 9% of the population is still uninsured. So as we look at this piece here, this is where I'm going to focus today, is on this job-based coverage, this employer-sponsored health insurance. And it has really begun to weaken over time. And that weakening you can see in a few different forms. The first is that fewer employers are offering coverage. And I want you to focus in particular on this. About 60% of all firms down to about 56% of all firms offering coverage over time. So fewer firms are offering coverage than did historically. Now you can see here, just a note as we talk, of the large firms, most still offer coverage, but it's this kind of, the medium and the smaller firms that are less frequently offering coverage. And in particular, if you were to slice this data, you would see that firms that have, more part-time workers and lower income workers are also less likely to offer coverage or to offer coverage to those employees. And then the other trend that we see is that job-based coverage is becoming increasingly expensive. So again, this is 1999 to 2020. And what you see is a single plan where a worker signs up for coverage for himself or herself versus a family plan where they sign up for themselves and others, a spouse, children. And the cost has, you can see, increased quite dramatically over the last 20 years. One way, so employers are struggling to manage these increasing costs, and healthcare costs have notoriously risen faster than inflation. And so as this has happened, employers are trying to figure out, well, how do we contain these costs? How do we manage these costs? And one way they've done it is to shift these costs onto employees. And they've done this in a couple of different ways. So what you see here is in the last decade or so, you see overall inflation is down here. It's the light blue line, Workers' earnings are the dark blue line, and you can see workers' earnings sometimes grow slower than inflation and sometimes faster. What does always grow faster than inflation are their share of healthcare costs. So you see here, this is the cost of what a worker pays, family premiums for a plan. So if I were to elect through my job, as I do, to cover myself and family members, I pay a share of that every month, and that cost is growing at about 26 at a rate that's much faster than inflation. And then you see the deductibles, which is the amount that I pay before my plan starts to pay. So the first $500 or the first $1,000 of coverage before my plan starts to kick in, and that's growing at a much faster rate than all of these other pieces. And so what does this do? Is it means that, I'm bearing, people with employer-based or job-based coverage are bearing a larger share of the costs of their health care. And as a result, what we're seeing is a larger number of people who have coverage through their jobs are underinsured. And so what does underinsured means? That means that somebody, even once they have insurance, might have a hard time paying for their health care. Based on one definition, underinsured is somebody who spends more than 10% on their healthcare, not including the premiums, not including the upfront cost of their care, or 5% if they're low income. This increase is driven by a couple of different things. First is that these plans tend to cover a lot, and so we're seeing plans. But the second and the more prominent driver of this increase is that the prices are growing very quickly in these plans, the prices that employers are paying for care. So employers are paying about twice as much for hospital care than Medicare does, and one and a half times what Medicare pays for outpatient care, like for going to a doctor. And the costs of those prices of what employers are paying for coverage have tended to grow faster than, unsurprisingly, than what Medicare pays, because Medicare can kind of has, it's large, right? It has large bargaining power, and it can push back on a hospital or on a doctor and say, if you want Medicare patients, these are the prices we're going to pay. And generally the hospitals and the doctors say yes. The employers don't have that same kind of power for the most part. And so you see that these employer plans are paying a lot more for the same care than what Medicare pays for them. Now, you probably have heard that hospitals say they have to charge private plans these higher rates in order to subsidize Medicare. But if you look at the data, you'll see that aggregate losses are at about 10% overall for hospitals. And that includes inefficient hospitals. If you look at just the efficient hospitals, most are just below break even on only Medicare reimbursement. So, especially with the fact that employer-sponsored health insurance is a larger share it pays for a larger share of the total care than any other single source of health insurance. It's hard to believe that these rates are necessary just in order to subsidize other forms of insurance. Even when employers try to do better, we've seen them struggle. So really quite famously in recent years, we saw the folding of a venture called Haven, which was a joint venture by JP Morgan, Amazon, and Berkshire Hathaway. So you get three, large, powerful employers coming together trying to address this problem, and they weren't able to do it. There's a number of reasons why, but one was that they've had a hard time moving the needle on price, even though they were, relative to other kinds of employers, were relatively large and powerful. In a recent survey of decision makers at over 300 large private employers, this was done by the Kaiser Family Foundation and the Purchaser Business Group on Health, nearly all said they were concerned with this problem of excessive costs on health benefits. This is if you were to listen in to large employers, benefits offices meeting, this is what you'd hear a lot of them talking about, is how are we going to be able to handle this going forward? So the share believing that in the next 5 to 10 years, the cost of providing health benefits will become unsustainable, 87% say yes. Need for greater government role in coverage and costs, 85% say yes. And so they're getting to the point they say, we need help. We can't manage this problem on our own. And then we're also seeing, so we have employers struggling. It's translating into employer coverage not being as good as it used to be. And then we're seeing secure jobs that come with health benefits potentially declining and maybe becoming less common over time. So we see a larger number of jobs that are gig jobs or contingent work. and we see trends where this kind of work, or work where people are working as independent contractors, may over time take up a larger share of the workforce. And we see employers intentionally structuring this way in some cases in order to avoid having to provide kind of the soup to nut health benefits that they used to provide their workers. So this was the foundation on which the pandemic occurred. And in the early days of the pandemic, we saw about 15 million people lose jobs through which they got health insurance coverage. What was amazing in watching this happen was that most of them picked up coverage elsewhere. So we had a number of different things that made this happen. Some companies kept people on voluntarily on their health benefits, even if they were furloughed or laid off for a temporary period of time. We saw people turn to spousal coverage, turn to COBRA, which allows them to pay for and retain their job-based coverage for a period of time. We saw them turn to public insurance like Medicaid or CHIP, and to the ACA marketplaces. So there were all these other places people turned. And then we also saw the gaps that happened afterwards. So about 2 to 3 million people remained uninsured. And so where I was turning to was the fact that we saw the largest gaps in coverage during the pandemic in the states that didn't expand their Medicaid programs under the ACA. So what you see here is uninsurance rates among unemployed adults during the pandemic, and the largest rates, the darker states, are in some of the Medicaid non-expansion states. So states like Texas and Florida and some of these states in the South. Part of what we saw during the pandemic was that this having health insurance rely on jobs made regulators have to scramble to fill in the gaps when people started to lose jobs. So we saw the Families First Coronavirus Response Act putting a number of measures in place to try to help people retain job-based coverage, to encourage states to keep people on their Medicaid and CHIP programs. We then saw later the Biden administration stepping in and through executive actions and a number of different things trying to help people maintain or find new sources of health insurance coverage. The American Rescue Plan Act in 2021 enhanced the dollars to help people buy health insurance through the ACA marketplaces, and the Inflation Reduction Act just kept those premium tax credit enhancements in place for until 2025. So we had to see a lot of voluntary work by employers and work by regulators to try to keep the bottom from falling out for people. And so together, this picture made us ask whether in the long term, job-based health insurance coverage was really working. And once you start asking, well, is it really working? And you start to think about alternatives, you have to imagine a better alternative to encourage people to want to shift off of this kind of coverage. So let me map out a few possibilities for you, and I'll spend the most time talking about an idea that I worked on with a couple of co-authors in recent years. So I'm going to map these out on this matrix for you, from what I'm calling kind of incremental efforts to more sweeping efforts, and lower quality insurance alternatives, so where what people get might not be as good as what they were getting through their employers, to higher quality insurance alternatives. And I'll talk briefly about 4 different things. These things called ICRAs, removing the ACA firewall, the idea that I've been working on called an employer.
Well, while we're on, and I see, let's just start it over again. I'm thinking about having a question I'd ask, having been at this a long time, when, the employer, it was a big, the tax incentive was a big driver for employers to provide this. It's still there, but the employers used to pay for everything, and it was easy for employees. And once it started to get complicated, the employers aren't doing what they used to do. They're providing some cash, but they're not really helping the employees that much. Pick a plan. They give you 5 plans, you pick your own. A lot harder.
Yep.
It's almost like you're doing it on your own as opposed to doing it through your employer.
Right. Though with a lot less choice than you might have had if you really did.
Because what we looked for was, it was so easy to say, well, the employer gave you health and disability and paid for almost all of it. It was an easy thing for the employer to do. But once you're on, even if the employer provides it, but you're on your own to work through the plans, it is not easy.
That's true.
The other issue we might ask her to consider is the impact of mandated benefits. For the longest time, the small business community has said that the ever increasing number, which is questionable, of mandated benefits has driven down their ability to provide this coverage.
Well, while you're looking, maybe you can zoom in. I was just thinking about how many of us on this call have worked with insurance companies that used to provide all lines of insurance, health, disability, everything. And then over the time, it just changed completely. So that you either do health insurance or nothing else, but you don't do health insurance.
Yeah.
And it's really changed the complexity and the way it works. I do think that's why I was really interested to hear what you would say about where we're going, because it's more and more on the individual. In any event, the employer's role is smaller than it used to be, both in terms of the financial contribution and in terms of helping make the decisions about which insurance to pick.
And Walter, also in the large employer space, many of them have ERISA qualified plans that take them out of the scope of any state regulation that also might disincent people to be providing insurance.
Yeah, I just think it was expensive. It was easy for so long just to say, here, you get this as part of your salary. And remember, I don't know whether she covered this as well. There was once wage and price controls, and that health insurance contribution was outside of those wage and price controls. It was one of the reasons that health insurance really developed in the employer market, was the employers could do it and provide this benefit without running afoul of the wage and price controls.
And you're talking about the Truman wage and price controls.
Yeah, it's way back.
Way back.
It's way back. I wasn't there, but
nor was I.
But I mean, that was the driver, and I just think employers have, I've worked with a lot of employers over the years. They've been moving further and further away from the responsibility for this.
Which sounds like she would agree with that part for sure.
Yeah.
Okay, let's give this a try again.
All right.
Okay, my computer's still making a lot of noise, so hopefully it will cooperate here. Okay, so I was talking about the fact that it took a lot of effort to try to keep people insured during the pandemic, and so people started to think about alternatives. And we could think about these alternatives on an array from incremental to sweeping, and from providing lower coverage insurance to higher quality coverage insurance. And so one of the ideas that floated was the idea of individual coverage health reimbursement accounts, or ICHRAs. And what these essentially do is it's a voucherization of employer-sponsored health insurance, where the employer gives employees some money and says, go to the ACA marketplaces and buy a plan. And what we saw with this proposal, as people started to look at it empirically, is it would relieve employers, but it wouldn't help most workers. So it would control the employer spending over time. But what you saw is that a lot of workers would end up with lower quality plans. Some of them, ironically, if the employer provided a little bit more, wouldn't be able to get those ACA subsidies to help them buy plans. And especially older workers or lower income workers who had to pay this full cost of coverage would go onto the marketplaces and have to pay relatively higher costs for coverage, and would end up a lot worse off at the end of the day. So it's an idea that it's a patch, especially for small employers who can't provide coverage, who are not providing coverage at all right now. It could start to fill in some gaps, but it's not really a longer term solution. We also saw people talking about removing this thing called the firewall for ACA coverage. And so the ACA has an intentional design where if somebody's offered coverage by an employer that is, by statutory definition, both adequate and affordable, that it provides decent coverage, where the cost of coverage is less than 9.8% of household income, they can't get subsidies to buy an ACA plan on the marketplace. So what's even more, so what it's saying to people is, if you get decent coverage through your employer, stay with your employer plan rather than coming to the marketplaces, where tax dollars would have to subsidize your coverage. But there's a piece in this design that's called the family glitch, where it says, when we determine what's affordable, we'll base it on the cost of individual coverage for one person, not family coverage. And family coverage can be multiple times the cost of individual coverage. And so somebody might have coverage that's affordable on for an individual plan, but if they want employee coverage, it would cost them way more than what they could afford to get it through their employer. But having this affordable coverage not only disqualifies them from getting subsidies, but would disqualify the entire family from getting subsidies on the exchanges. And so a lot of people have said these policies don't make sense. Remove this firewall, and if it's better off for somebody to get subsidized coverage on the ACA marketplaces, let them do so. Let them get those subsidies. Estimates show that especially in this world of enhanced subsidies, where we are now, at least through 2025, that it would make about 13% of households enable them to get a policy at a lower cost if they could go through the marketplaces instead of through the jobs. The challenge is that they might find at the end of the day that even though the premiums are less expensive, that they can actually afford that coverage, when they need to use health care, these policies are going to provide less. They're going to cover less. They're going to require more cost sharing than the employer plan did. So they may find that they're underinsured at the end of the day. So it's just a patch. It is a patch that would disproportionately help lower income workers and people who and workers of color who are less often offered coverage now and are less able to afford that coverage when they take it up. Let me turn to an idea on the extreme opposite end, which is Medicare for all. When people say Medicare for all, they mean a lot of different things, but at the core, they typically mean a single payer system. The government sets healthcare prices. They provide at least a baseline of health coverage for everyone. Bernie's version was much more than a baseline, but all the different versions of Medicare for all provide some kind of baseline of coverage. Most health policy experts agree, especially if you look at global comparisons, that government financing of healthcare is more efficient and more equitable. Most also agree that it's really hard to get from where we are now to that point, in large part because of the sticker shock of doing so. So what happens is when you start to look at Medicare for all and you think of the budgetary cost, you think of the fiscal price tag, it's huge. It takes all the dollars that the employers and that individuals are paying today for coverage and shifts them to the federal budget and then has to be financed through taxes. So politically, as those of you who followed the last primaries know, it ends up becoming a political non-starter. It's also a proposal where you see vested interests who profit based on the current system, strongly resisting this kind of proposal, because for many of them, it would take business out of their hands or would mean that they're paid less to provide health care. We did see a couple of candidates in the last primary talking about things that were more incremental transitions and recognizing that transitioning from where we are now to something that looks more like Medicare for all is really hard. And so these kind of two pieces of the conversation, the sticker shock and also this transition problem, is what motivated my two co-authors and me to work on a proposal for what we call the employer public option. So the idea of my co-authors, I should say, are Howell Jackson, who's at Harvard Law School, and Amy Monahan, who's at Minnesota Law. And Howell and I have worked together for a while now. We wrote our first piece together over 10 years ago, thinking about how well people understand what they might have to pay out of pocket for healthcare when they're on Medicare, and doing some empirical work to try to understand how people think about their healthcare costs in retirement. And he's an expert in particular on financial regulation and budget policy. The other co-author is Amy Monahan, who's an employee benefits and tax guru and is really one of my most trusted people and interlocutors in this space when thinking about the details of health benefits design and regulation. So we started to brainstorm the possibility of a more incremental and organic way to loosen reliance on this employer-based coverage in places where the continued reliance makes the least sense. And what we propose doing is introducing an employer public option, looking for an idea that might be politically and practically feasible in the short run, and also create the opportunity, the potential for more structural change in the long run. So the basic idea is to create a public option based on Medicare to offer to employers who would select it for their whole group of employees. They can choose to offer this public plan instead of the current private health plan that they're offering. And it would be their exclusive plan. So once they offered it, it would take the place of their current plan, not an option, not one among many on a menu. By making this choice, an employer would loosen the knots binding the existing system themselves at the point that they said, this makes sense for my business, it makes sense for my employees. What differentiates it from its more famous cousin, the individual public option, is that the person or the entity that is making this decision, that is making this shift, is the employer rather than individuals. And we like this as a starting point because it does a couple of things. It offers relief to employers who want out of the business of providing health benefits to their employees, being the one who has to design it and negotiate with all the different providers or hire an insurer to do that on their behalf or a third-party administrator, while ensuring that their employees still get good benefits. And it also starts to think about how do you build the foundation for a better healthcare financing system 10, 15, 20 years down the line, if expanding Medicare coverage to working age populations works well. So it's a way to test this notion more incrementally and intentionally. Let me go a little deeper. So this is where it focuses, is thinking about a little sliver of this employer coverage, and a couple of policy details just to go a little deeper, and then I'll stop because I want to have time to take your questions. And I can go over 5 if you all are willing to stay on late as well. So the first is that it would be voluntary. When you think about the individual public option, it looks to individuals to compare and select among health plans. And there's a lot of literature out there that says individuals have a really hard time doing that and tend to not do it well. But employers, especially large employers, are more sophisticated purchasers of health benefits. They have the resources to try to figure out among many options what might be best for their business and employees. They have consultants who focus on helping them design their health plans. And so we think that they might make more educated decisions in this space, although probably not perfect. There's evidence that shows that sometimes they don't do that well either. We also think that if the employer makes the decision and offers that plan to their employees, it could soften employee resistance to a Medicare-based plan. It's instead of coming from and being imposed upon them from the government, it comes through the employer, through a channel that they're used to. It also, moving it through the employers, helps to make a better fiscal case, which I'll talk about in a moment. It's not this kind of whole movement of all the financing onto taxes as Medicare for All does. The second thing is that we would focus on large employers who are kind of this more sophisticated site for distribution and testing. And there's a number of them. There are 12,000 firms who have more than 1,000 employees, on average about 6,000 employees a firm. And if a few of them were to opt for it, it could provide the chance to kind of beta test and refine the idea. And then if it worked, these would be wonderful spokespeople to try to catalyze more people to opt in. And so assuming that it worked in its early stage, or with refinement worked, we could imagine eventually reaching something that looked not like Medicare for All, but Medicare for More in a kind of incremental way over time. Pricing and financing are hard. You would have to, and you could design it so that it's attractive to large employers, and ideally so that the employees are as well off or better off at the end of the day as they would be under their private employer plans. So you'd probably have to pay more in this plan than the current Medicare rates, but not as much as the employers are spending now for care. So the price would be somewhere in the middle, which would mean that the average family plan of over $20,000 could cost maybe a few $1,000s less a year, translating into savings for employers, and depending on how you design it, possibly for employees too. And so it has the potential over time to reverse this steep growth in healthcare prices and spending that has happened over the recent decades. It would also have to, in terms of benefits, proxy what large employer plans do today to have appeal. In some regards, this would be easy. Medicare is actually pretty good coverage. It's extensive. It pays for things that are medically necessary. But in other ways, it's hard. So for just one example, cost sharing in Medicare is actually higher than in most large employer plans. So in technical terms that will probably make sense to this audience that don't make sense to all audience, Medicare has an actuarial value of 73% as compared to as high as 90% in large employer plans. So the average large employer plan is just paying for more of the share of healthcare than what Medicare does today. That gap would have to be closed. Provider networks and those reimbursement rates are closely intertwined details. We propose tying participation in Medicare to participation in the employer public option. So if somebody wants to participate in Medicare, which large hospitals and many providers want to, they also have to be willing to play in the employer public option. But the goal would be to set the reimbursement high enough to make them willing to do so, right? So that it remains an appealing kind of slice of business for them. And there could be formulas to adjust reimbursement over time as more employers phase in. A great benefit of this proposal could be continuity of coverage. So you can imagine if lots of large employers over time had the employer public option as their plan, you could move from one employer to another and not have to go through election of a new plan again, not have to face disruption in your providers in the terms of your benefits. It would just look like kind of seamless coverage, even if you switch jobs over time. A big question is whether employers will be interested. We think they should be for a number of reasons, and early conversations with employer groups have been encouraging, suggested that some might be. It could solve a number of problems for employers. The freedom, most importantly, from having to manage the healthcare cost growth, these increasing prices, and their inability to push back against the prices. It could provide them administrative simplicity. Right now, they run small businesses of providing healthcare benefits. They wouldn't necessarily have to do that at the same level to deal with ERISA and tax law and all these other complicated areas of law. It could reduce conflicts. Right now, there are sometimes conflicts with employees over benefits denials, over the sharing of health data, which people are nervous to do with their employers. And it could help to get coverage for more low-income workers, to keep dependents in plans over time, and to make coverage more equitable if it is well designed. One way to do that, which I'll just mention briefly, is that you could take these ACA-style subsidies that subsidize lower-income people to buy coverage, and you could fold them into an employer public option. So essentially, the employer would pay less of the share of coverage for employees who are lower income. So this shows you right now, this chart shows you that the lowest wage workers here are largely not in their employer plans. They're either not offered coverage or they're offered coverage and they're not participating in these plans. If employers had incentives, for example, if the government were subsidizing a large share of the costs of providing coverage for those workers, there would be more incentive for employers to want to weave all of these workers into their plans. It would make the proposal more expensive, but it would reach a piece of the population that could be quite tricky to reach over through other policies, and that are actually now made and many times worse off by being offered employer coverage if they can't afford the cost of that employer coverage, and then it disqualifies them from subsidies in the ACA marketplaces. It doesn't mean employers will jump at the idea. There are a number of impediments. Some are practical, inertia, belief that private plans help them in recruitment of certain employees, which is sometimes true. Sometimes employers are providing access to fancy doctors and hospitals that aren't provided otherwise to be able to get kind of their high level executives, but some obstacles are political, as is always the case with health policy. But we think that the benefits would over time kind of outweigh some of these obstacles. There are fiscal and budgetary advantages. So I've alluded to the fact that and to make explicit, the current contributions that both employers and employees are making could be retained in whole or in part to finance a significant share of this form of public option. So instead of wiping out all employer coverage, trying to raise the dollars through taxes, you could retain a lot of these dollars that are currently going into health plans, and it would make this kind of on budget cost lower. So if they were paying in, the employers and the employees, for premiums on an employer public option, it would be something that is technically called an offsetting government collection. It's a voluntary exchange transaction. It's not part of a taxing and spending program, and it doesn't show up on that fiscal budget bottom line. And then, it would also enable talking about the kind of the shift away from employer coverage in terms that make sense for people. With Medicare for All, there were a lot of talks that relied on explaining how, at the end of the day, labor market effects on wages would offset the imposition of new payroll taxes and these things that really relied on complicated economic effects that didn't make sense in public debate. And then, I'll just mention in passing that we think that if well designed, this is the kind of policy that could be passed through reconciliation in a moment where it's hard to get anything through Congress. Having policies that fit that kind of mold are important. So it may not be the right answer overnight, an employer public option, but it might also be that building incrementally on the individual market, as many of the proposals out there do, is not enough for 10 or 15 years from now. And so the ideal is to try to find a space between these two extremes. And we think an employer public option offers that. It creates kind of slow incremental change, the opportunity to test something out in the short term. And if it works, it builds foundation for health insurance coverage that is kind of more stable and more equitable over time as the future of job-based coverage gets less steady and also starts to look less wise in the face of a pandemic affecting the way that people were getting health insurance. So let me stop here, take your questions, and I'm sorry again for the technical problems.
No need to apologize. So the queue is open, and if Allison, you said you could stick around for an extra 5 minutes, is that?
Yes, absolutely.
Okay. So I might jump in with the first question and while we're taking the queue, and then followed by Walter. So I mean, it's a fascinating proposal, and it seems to me to be very plausible in a way that a lot of them aren't in this area. It seems like there's a sort of background theory at play here with regard to like what is the best way to decrease the rising cost of healthcare, or stated differently, like what's driving the rising cost of healthcare. And implicitly in this argument, it seems to be that there's a negotiation leverage problem, and that is the thing that will be added here that we don't currently have. But there are many other reasons why healthcare costs might be increasing, and other things one might do to attack those other reasons. So why focus on? I mean, do you think? I guess the question is, do you think that the negotiation problem is the main driver of healthcare, and that's what's motivating this theory, or do you think there are other main drivers of healthcare cost increases that just aren't addressed by this theory?
So the data shows that like if you look at the US versus other countries, I think I have a backup slide in here that would show this. Okay, so the US spends more. So this is the US here. We spend twice as much as kind of most of our peers on healthcare. So this is the OECD average here. This data is a few years old, but the next closest neighbor is Switzerland here, and still we spend 50% more than they do. So it would be okay if we got really good results, but we don't. We spend more, we get less. I love this slide because it shows healthcare spending per capita going up across the x-axis, life expectancy on the y-axis. You could choose lots of other measures that we care about, and it would look quite similar. So why is that? Why are we spending more and getting less? If you look at, there have been a number of rate studies that have shown where we diverge. And one of the main reasons that we diverge is that we pay more for every unit of care than what other countries do. So for every day in a hospital, for every surgery, for every drug that somebody takes, we're paying more than what other countries are paying. And then there's a sub issue under that, which is that we're doing things in more expensive ways as well. So we might do something by sending somebody to a specialist, whereas in another country they would do that same thing by sending somebody to a general practitioner whose hour or half an hour would be less expensive. But what we do know is that we're paying more per unit of care than in other countries. And in other countries, what they do, whether they use one single payer system or whether they have something more complicated, is that they set rates. They have some kind of budgetary mechanism through the government. And so they have some kind of cap on rates or some kind of rate setting mechanism that is done in a more coherent, public policy oriented way than what we have. As you shift things into the Medicare program, you have the potential to do that. You don't have the certainty of doing that. There's a lot of things that happen in reimbursement in Medicare that don't make sense either. But as you start to create a more eloquent system where that kind of decision making can happen in a central way, you have the potential to think about things like, this is what we should really be paying for this unit of care. And this is a valuable thing that we're giving patients, and this is a less valuable thing. And so let's pay more for this valuable thing than for this less valuable thing. Of course, this is where the more you move people into Medicare, the more you try to make those kinds of decisions centrally, then that's your next layer of contentious debate, is what should we be paying more for? What should we be paying for, period? And that doesn't go over well, right? It leads to conversations around death panels and things like that. So it's not that it's easy, but at least instead of leaving that to every employer to try to do individually, it moves it to a more centralized function, and then that's where you shift your attention and your efforts.
Great, thank you. Walter Welsh.
Yeah, just a question on the employer public option. If employees, will they have a choice if the employer chooses the public option to go elsewhere? So the employer would either put the money towards the public option or give them cash to use it elsewhere?
I think it should work the same way as employer coverage does now, which is, and that differs based on employers, right? And so, there are some employers now where if you don't take up the job-based coverage, they might offer you something else. But I don't think it should be something, and some don't, right? And so I think like you could fit into the same kind of parameters. I don't think I resist the idea of it being a choice among many, because there's a lot. I wrote a piece called Healthcare's Market Bureaucracy, which looks at the notion of how choice plays out in health policy in theory versus in reality. And the reality is that it's really hard, especially when it comes to health insurance, for people to make good decisions, even if you try to steer them towards good decisions. So I really resist policy proposals that try to put the choice into the individual's hands.
I understand. Just on the dollars, can the employer change its contribution over time and say we're gonna pay less, so you employer, you're gonna just shift the cost down to the employee? Is that what will happen under your option?
So and of course the first proposal is kind of at the highest level. And so the way that we set it is that the initial contributions wouldn't allow them to kind of pull the rug out from under the coverage that they were providing. If an employer provided, were extremely generous, it might be that their contribution is pegged more to what an average employer were providing rather than their extremely generous coverage. But they would have to, if they wanted to be part of it, they'd have to pay in a certain amount of the cost of coverage over time. And that could vary over time based on kind of what their total employee population looked like. If they had more lower income workers, they might pay less of a share for those workers than if they didn't.
But if they chose the option, that's their premium.
That's right. That's right.
Thank you. Go on to your next question. Thank you very much. Very good presentation. And the stop and go didn't bother us.
Good. Sorry about that.
No problem. No problem.
Bob, yes.
So I didn't want to detract from the end part of your presentation on possible solutions. This is really intriguing, but I was interested in sort of your opening premises about the declining share of small and medium-sized employers providing health insurance. And at least the assertion has often been made in the public policy debate that the insured marketplace, small and medium employers, as opposed to the self-insured large employer marketplace, are subject to mandated benefits. And over time, as more mandated benefits have been layered on, it's driven small employers, medium employers out of the marketplace to provide insurance. So I'm wondering whether you've studied that at all as one of the factors, leading to this increasing problem.
So the trends move in both directions on that. So we've seen in recent years, I haven't studied that specifically, but I don't think it's a clear story with that being kind of the causation. So we've seen things like, the ACA put more mandated benefits into place, but it has, for example, exemptions for employers of a certain size, or in the early years had subsidies for employers of a certain size. We've also seen more smaller employers self-insuring, so moving out from under those mandates than ever before. And there was a large trend in that direction in the years since the ACA. So I don't think I think the piece of it that if you talk to those employers that they say that you're going to hear more often is that even apples to apples, the same policy year to year is getting just exponentially more expensive.
Thanks.
Maggie Marolo.
Hi, thank you for presenting. One of my questions, it's I guess a little bit tangential, but is about your perception or thoughts about cost sharing, like high deductibles and co-pays and things like that, and whether you think that because of what you described as the United States paying more per unit of care and consumers making poor decisions when allowed to, that having these like theoretically good ideas of cost sharing end up making our healthcare costs more expensive because people delay care or make poor choices in terms of preventative and getting help in the early stages, and then end up paying more when the problem's worse?
I mean, that's like the $1 million question that lots of health researchers have been trying to answer. So, how does the design of health insurance affect affect uh, affect kind of health outcomes at the end of the day is what you'd want to look at, right? Not just do people use preventive care, but then does that use of preventive care lead to health at the end of the day? And so this tracks back to the famous Rand health insurance experiment of decades ago, which suggested that it doesn't make that much difference, and then has led to, I mean, hundreds, thousands probably of studies since then. A piece that I follow closely that has really intrigued me is that we're seeing increasingly in plans that have high cost sharing, especially among older people. So there are some good studies that have come out of Canada recently, and also some good studies that have come out of retiree health plans in the US that show that people don't do things like take their prescription drugs that would, that are really critical for health outcomes, and that they then land in emergency rooms more often. And so, like in the past 5 years, there have been a handful of studies that show that. And so, I think I think the body of evidence is moving in that direction, showing that these kinds of tools that have, for example, higher deductibles or higher cost sharing across the board, that people don't respond to them in the way that they're supposed to, which is, in theory, they're supposed to use less bad care and more good care. But that's a really nuanced kind of differentiation for individuals to have to make. And so what do? They just cut out care. And if that care is really important for their health, I think increasingly we're seeing with these kinds of plans, detrimental health outcomes. So long answer, and it's not one that is, I think you see mixed evidence out there. But I think the evidence is going to start to shift in the direction of more concern over this kind of design.
Thank you.
So we have time for I guess, one more question. The queue is open. I'm tempted to call on a student who wrote a very good question in a response, but I don't want to surprise anyone.
No, do that.
All
Surprise.
right. So Lauren Kidd, you had a really good question in your response paper about trust in government versus trust in employers. And do you want to ask that one?
Sure. I guess my question is, so how would your envisioned plan for government-based employee health insurance or a government employee-based health insurance plan protect health information of citizens from government access? And that was really just a question that I thought of in response to kind of like post-Dobbs, and how a lot of states are looking into criminalizing abortion and such things. And so them having access to that could be really bad and ultimately be a deterrent for people like seeking healthcare or have access to health insurance.
And to even to amplify that question, one question that I got sometimes as I talk to people about this idea is, you shift more things into Medicare, into government policy, and then you have administrations that have differing goals, right, from one administration to the next. And now you've leaned more on the federal government in order to kind of be the single source of health insurance. And I mean, I think that's a real concern. I think the health privacy concerns you'd have to think about, and on both of these, right, what are you relying on as the check? You're relying on democracy as the check at a moment that many of us are questioning whether democracy is working that well anymore, right? Because the federal government does a bad job. And what do? Well, you're supposed to use your, kind of your votes as individuals, or your elected representatives are supposed to represent, your health privacy and your other interests. I think I think these are real questions, and I don't think there's an easy answer to it. I think we've seen better regulatory solutions from the federal government on health privacy, and some kind of consistent kind of policy in that regard could be really useful. People trying to parse what individual providers or companies are doing on health privacy is really hard to understand. And so, like, for example, there's been a lot of talk with like the new use of technologies and if employers adopt those technologies, what is protected and what is not. And even experts on health privacy look at the law, and it's hard to decipher the line of what's protected and what's not. So my gut is that if you have like one hub and source, you could develop a more coherent policy, but you would have to have a government who wants to protect health privacy. And so I think that that is a definite risk. And you'd have to have a government who wants to use dollars to make people healthier at the end of the day. So it is a true and genuine risk of shifting more towards a single source for coverage.
Well, thank you. On behalf of everyone else here, I'd like to thank you, Allison, for presenting a brilliant presentation and for your patience in working through our IT difficulties. We're very lucky to have you. Thanks again for coming.
Thank you all. Thank you for your patience today. It was nice to be here with you.
Okay, thanks, Allison. Bye.
Bye-bye.
Bye, everybody.